For the motor portion of the examination maneuvers are going to consist of manual muscle testing, and it's going to include reflexes, and it's going to include girth measurements of both the thigh and the calf. And so we'll talk about each of these manual muscle testing, reflexes, and girth measurements here in sequence. Now, interesting is that the AMA guides do not provide any specific mention of the technique for manual muscle testing. There are many references throughout chapters 15, 16, and 17 as to manual muscle testing and the use of manual muscle testing for determining strength losses. But interesting is that the guides don't prescribe any specific technique, tips, suggestions, or method for manual muscle testing. And so I'm going to provide some of those here now myself for you to use. And the techniques that I'm going to share with you are taken from specific references that give detailed discussion of manual muscle testing, and I'll just describe those references to you here now. Number one is a textbook entitled The Technique of the Neurologic Examination. That's by DeMeyer, D-E-M-E-Y-E-R. Another reference is entitled Fundamentals of Musculoskeletal Assessment Techniques. That's by Palmer and Epler. Those are a group of physical therapists. Another reference that contributed to this section of this program is a book entitled Muscles, Testing and Function with Posture and Pain, and that's by Florence Kendall, probably the queen of muscle physiology. And then finally, a textbook entitled Muscle Testing, Techniques of Manual Examination by Daniels and Worthingham. Now, when we test for manual muscle testing, of course, is largely dependent upon examinee cooperation. And so the very fact that cooperation is required tells us that there's a conscious component involved with manual muscle testing. And so let's just refresh our memories on, therefore, the circuitry involved with our testing, the neurologic circuitry, that is. When you explain to your examinee the manual muscle testing procedures that you're going to do, those communications are consciously accepted by your examinee at the conscious level, at the cerebral level of the nervous system. And so for them to participate with you, the conscious attempt to produce strong and full muscle contractions begins at the primary motor areas of the cerebral cortex. And from the primary motor area of the cerebral cortex, intentioned motor impulses arrive down at the ventral horn in the spinal cord, basically by two basic pathways. The first is the lateral cortical spinal pathway, and the second is the anterior cortical spinal pathway. And in another program entitled The Importance of the Neurologic Exam, we go over extensive sections of Chapter 15 of the AMA Guides, and we talk about the impact of cortical spinal tract injuries on spinal function. For this program, I just want to say a couple things, and that is with the lateral cortical spinal pathway, this is the pathway that's involved in providing motor impulses to skeletal muscles in the distal parts of the limbs, whereas the anterior cortical spinal pathway provides for motor impulses to muscles in the trunk and in the more proximal parts of the limbs. So with the lower extremity, we're going to be testing both proximal and distal portions of the limbs, specifically of the legs. So we're testing both pathways. And just to refresh your memory about the cortical spinal pathways, these upper motor neurons have their nerve cell bodies in the primary motor areas of the cerebral cortex. And you might remember back from neuroanatomy classes the motor homunculus that lay draped over the cerebral cortex. Well, in this case, we're testing the leg portion of the motor homunculus. And the neurons of those cell bodies send axons down through the midbrain, through the cerebral peduncle, and those axons decussate, cross over at the medullary pyramids, and then they descend down the spinal cord. Excuse me. They descend down the spinal cord in the lateral cortical spinal tract, where they then synapse with the lower motor neuron to send motor impulses to particular muscles, particularly in the distal parts of the limbs. So in the case of the lower extremities, this would be in the lower leg, ankle, and foot area. The anterior cortical spinal pathway, on the other hand, does not decussate at the medullary pyramids. Rather, it continues down the spinal cord to reach the segmental level of synapse, and then at the segmental level of synapse it makes its decussation from one side of the spinal cord over to the other side of the spinal cord, where it then synapses with the lower motor neuron, and in the case of the anterior cortical spinal pathway goes out to innervate muscles in the proximal parts of the limbs. So with regards to the lower extremity, we would be talking about the gluteal muscles, be talking about the hamstring muscles, be talking about the hip flexor muscles, etc. And we'll describe the manual muscle testing procedures for each of those muscles. Now, a couple general principles for manual muscle testing. Specifically and in general, you want to select movements for the examinee to resist that would just about match your arm and hand strength. Let me repeat that. You want to select movements for the examinee to resist that would just about match your arm and hand strength. Select movements that are neither too strong for you to possibly overcome, nor too weak for you to judge their resistance. Now, in the lower extremities, we're dealing with muscles that are extremely strong, especially the anti-gravity muscles of the gluteus, of the quadriceps, of the gastrocnemius muscles. These are extremely strong anti-gravity muscles that are way too strong in their strongest positions. They are way too strong for you to possibly overcome. I mean, try to overcome with your arms and hands, try to overcome someone's ankle plantar flexion strength. You basically cannot do that. So in some cases, some of these manual muscle testing maneuvers need to be modified in order to find a position where the muscle is somewhat weakened and can therefore be reasonably tested by matching your strength against their strength. Okay, so in general, want to select movements for the examinee to resist that would just about match your arm and hand strength. And some of those maneuvers for the lower extremity are just about matched for our arm and ham strength. For example, testing resisted hip flexion. That's a maneuver for the examinee that they can just about resist when you apply maximum arm and hand strength. On the other hand, testing resisted knee extension, with the anti-gravity quadricep muscles, that maneuver requires a little bit of modification because that's an extremely strong muscle. And we'll talk about some modifications here as we go. Principle number 2 is to understand that muscles are strongest when acting from their shortest length and have little or no strength when acting from their longest position or their longest length. So therefore, to test muscles of weak or modest strength, start with the muscle in a position of strength. To test for very strong muscles, such as in the lower extremity, place the muscle in a position of disadvantage to bring them within your own range of strength. And this is something that we can do with the quadriceps, for example. With the quadriceps for manual muscle testing, picture your examinee lying supine on your examining table with hips and knees flexed to 90 degrees. Well, at the 90-degree knee flexion position, the quadriceps muscles are at about a midpoint of their length, right? If the knee was completely extended to 0 degrees of flexion, that's the shortest length of the quadricep muscle, and that's the position in which the quadricep muscle is extremely strong. Well, with 115 degrees of knee flexion, the quadricep muscle is now stretched across the knee joint such that it's in its longest position. And it's in this longest position that the muscle is relatively weak, and it's a position wherein you as the examiner are relatively strong. And it's a position in which you can gain some mechanical advantage and place them in a position of mechanical disadvantage so that you can get some sort of a reasonable match between your strength and their strength. Okay, so at least for the quadriceps, there is a modification, and you want to keep that in mind as to how you can apply that with some of the other strong muscles as well. Principle number 3 is you want to engage the examinee and get their competitive spirit involved in the game. You want to sort of make it a game of you matching them and see who's going to win this test of manual muscle testing. So encourage them to put forth their best effort. Always test in a repeatable superior to inferior direction. So for example, in the lower extremity, you would not start your manual muscle testing down at the foot. You would test superior to inferior, beginning first with hip flexion, hip adduction, knee extension, ankle dorsiflexion, etc. Testing superior to inferior, and make it repeatable and make it simple, something that's simple that you can basically just go through having done it 1,000 times. So make it a repeatable sequence. Make sure to always stabilize the proximal joint, the joint proximal to the joint that you're testing. This helps to prevent muscle substitution. And specific manual muscle tests for the spine and for the upper extremities are described in other programs. In this program, let's now discuss the specific manual muscle tests as we describe them for the lower extremity peripheral nerves. For the obturator nerve, as we've stated so far, the main function of the obturator nerve is in the muscle action of hip adduction. And so in your handout materials for this course, I've provided you with a templated description of the report of findings of your manual muscle tests, and you can simply import these findings into your QME reports. And by the way, I've read many reports, and I'm sure you've read many reports wherein examining doctors do not specifically describe, number one, their findings on manual muscle testing, and number two, the specific nerves that they test. And it's my opinion, and I want to know if you agree with me, that that when you describe in detail the nerves that you test, the movements that you test, the muscles that you test, and your findings, it's my opinion that that makes your report significantly more substantial, and it also makes your findings irrefutable. So let me give you a couple of examples here. This is how your report of your findings of your manual muscle test for the obturator nerve would look in your QME report. So it would say obturator nerve, resisted hip adduction using the pectineus, adductor brevis, adductor longus, adductor magnus, and gracilis muscles was strong and symmetric bilaterally, with no evidence of weakness or give way of either leg. This tests the motor portion of the peripheral obturator nerve and indicates normal function. Now, isn't that description much more substantial and much more credible and much stronger than a one-sentence description that states, for example, lower extremity muscles were normal, or lower extremity muscles were strong? Okay, it's my opinion that this elaborate description indicates to the parties your attention to detail and the accuracy of your examination procedures. Okay, well, what about the femoral nerve? Here's how your report of findings for the femoral nerve would appear in your report. It would say, resisted knee extension using the vastus lateralis and vastus medialis muscles was strong and symmetric bilaterally, with no evidence or weakness of give way of either knee. This tests the motor portion of the peripheral femoral nerve and indicates normal function. For the sciatic nerve, the tibial portion, you're going to do two different muscle tests. You're going to do resisted ankle plantar flexion, and here's how this would appear in your report. It would say resisted ankle/foot plantar flexion using the gastrocnemius muscles was strong and symmetric bilaterally, with no evidence of weakness or give way. This tests the motor portion of the peripheral tibial nerve and indicates normal function. Another test, because of the broad distribution of the tibial nerve, we want to include at least one more test. For example, resisted toe flexion. So your report would state that resisted toe flexion using the flexor digitorum longus muscles was strong and symmetric bilaterally, with no evidence of weakness or give way. This tests the motor portion of the peripheral tibial nerve and indicates normal function. And do you note that last sentence provides your reader with the conclusion? The conclusion is that you tested the motor portion of the peripheral tibial nerve and it has normal function. See, that is what makes your report credible, because your reader is not a medical person in most cases, and so they may not know about what all it means regarding resisted toe flexion using the flexor digitorum longus and all these anatomic terms, but you provide that there for them, and then you summarize your conclusions by saying that this tests the nerve in question and indicates normal function of that nerve. Okay, and then finally, for manual muscle testing of the common peroneal nerve, we're going to do here two tests also. And remember the distribution and motor function of the common peroneal nerve. down at the foot and great toe. So the first test we want to do is resisted great toe extension, and your report would state that resisted great toe extension using the extensor hallucis longus muscles was strong and symmetric bilaterally with no evidence of weakness or give-way. This tests the motor portion of the deep peroneal nerve, a branch of the peripheral common peroneal nerve, and indicates normal function. For another test, we would say that resisted toe extension using the extensor digitorum longus muscles was strong and symmetric bilaterally with no evidence of weakness or give-way. This tests the motor portion of the deep peroneal nerve, a branch of the peripheral common peroneal nerve, and indicates normal function. So, to review manual muscle tests of the lower extremity, I've just indicated here to you the main ones involving the obturator nerve, the femoral nerve, and both branches or both divisions of the sciatic nerve. You may also want to include resisted hip flexion testing for testing of the L2, L3, and L4 nerve roots. Specifically, the psoas is innervated by L2 and L3, and then the iliacus muscle is innervated by the femoral nerve, which is L2, L3, and then L4. And it's the iliacus, which is the first muscle that's innervated by the femoral nerve. The psoas muscles are innervated by L2 and L3 prior to being joined by fibers from L4, which signifies the beginning of the femoral nerve. So you might want to add in also resisted hip flexion. So the sequence of testing would go resisted hip flexion, testing L2, L3, and L4, down to resisted hip adduction, testing the obturator nerve, resisted knee extension, testing the femoral nerve, resisted ankle and foot plantar flexion, and you would also test that by doing the toe walk maneuver. That tests the tibial portion of the sciatic nerve. Down to resisted great toe extension and even resisted all-toes extension, testing the common peroneal portion of the sciatic nerve.